Hello, my name is Ron Broussard, and today we'll be covering Chapter 5, Communication. Okay, what we'll be talking about today is EMS communication systems, communicating within the system, team communication and dynamics, and then therapeutic communications. Now, within the EMS communication system, we have a base station, otherwise known as dispatch. Okay, dispatch is where we're going to be receiving our calls from, and we're going to be calling back a lot of information to. With this, it is a very high power unit, so 80 to 150 watts of power. They could really reach out with their communication system to get a hold of those ambulances. Now, we'll find out that ambulances need a little bit of help to communicate back. Now, within that communication center, there's a lot going on now. They're going to be receiving calls. They're going to be putting in information for calls, such as chief complaint, the address, and then they're going to be submitting that information to you on the ambulance. A lot of the stuff that helps us is computer-aided dispatch, where not only are we getting a radio report of, please respond to this house due to this complaint, but it's also going to pop up on our computers for, okay, go to this house for this complaint and even route us to that call. Now, also in the communication system, we have land mobile radio systems. Now, what we're talking about here is going to be mounted on the ambulance itself. So low power compared to a base station at a 10 to 15 mile range. Now, what helps them is the use of repeaters, which we'll talk about, which extend their range. Okay, so here's an example of an EMT on the ambulance using it to talk to their base hospital. All right, another portable radio. This is a little walkie-talkie that the EMT is going to be carrying. Now, you always want to make sure you have your radio whenever you're out of the ambulance, so that way you can communicate, ask for help if you need it. You don't have to run all the way back to the ambulance to get that help. Now, the thing is, if anybody's used a walkie-talkie, from Walmart, that it'll say on the box, it's like, oh, 1 to 2 mile range, and then you go and you try to talk on it and you can't even talk to your friend in the next room with it. So it is limited, especially if you don't have the use of repeaters that help relay that message along. Big thing, guys, don't get this mixed up if you see it on a test with mobile radios. So the mobile radio is a vehicle-mounted radio, where a portable radio is like a walkie-talkie that you carry with you on your person. All right, here's an example. All right, now repeaters. Repeaters are great because it helps us to take information, take that call from a low power system, okay, and then retransmit it and extend the range of our lower power radios. So that little radio that we have, okay, although it may be line of sight a mile, through the use of repeaters, we could get extended ranges out of it. Now, sometimes we have repeaters that are kind of like cell towers that are out there, fixed sites, and then other times we have repeaters that are actually on the vehicles. So the one thing with repeater use is there is a little bit of delay. Now, that is one reason why you actually have to key the mic, okay, wait a second, and then give, your call sign, who you're trying to call to, and then the message. Now, if you click the mic and then you start talking immediately, you're actually cutting out some really important information, like dispatch, this is unit 502, who I am, who I'm trying to talk to. So you want to give it a second or two to actually connect when you key the mic to help make that connection before you transmit anything. All right, and here's a nice little picture of how this all works out. Now, again, those portable radios really work through repeaters. Same thing with our mobile radios, can work through repeaters, extend that range to get to our base station. Okay, now, digital equipment. Now, what digital equipment allows is more radios to operate on crowded frequencies. So we have like different bands. Now, it utilizes encoders and decoders. Without getting like super technical, what you can think about is almost like like your talk to text in a sense on your phone that a lot of people use now. Like you're talking into your phone and it is putting in a text of information. It is taking what you are saying and putting it into digital data that you can send. So encoders and decoders, what it is it's taking your message, it's breaking it down into a digital form where it can send. A decoder will break it back down and turn it back into your message. Now, includes mobile data terminals that can transmit messages at the push of a button. Now, those are things like computer-aided dispatch. Again, our computers that we have on the ambulance are great because I can simply push a button and, report that I'm on scene. I can push a button and report certain information, and it makes it a lot easier, and it also clears radio traffic. Okay, mobile data terminal, here's an example. All right, cell phones. Now, cell phones are a wonderful advancement in technology. So much so that people cannot be detached from their cell phone. If you've ever left the house and you forgot your cell phone, you probably had like a mini panic attack inside, like, oh my gosh, what am I going to do? There was a time when people could actually be unavailable for 20 minutes and the world wouldn't end. But we're not in those times anymore. Now, with the cell phones, networks can become overwhelmed in disaster situations, especially if you're in an area that, doesn't have a lot of the infrastructure built up for cell phones. I used to live in Montana for a little while, and when we'd have bad winter storms up there, I would get, when I tried to make a call on my phone, and I had a reputable service, it was not able to complete my call. The system was down. Now, if you have a natural disaster and you have a lot of people on a network, it could easily overwhelm that system. Now, with cell phones, we all know excellent quality sound. You can kind of have more of a conversation type communication versus, dispatch, this is 502, stand by for patient report, like stuff like that. Whereas with a cell phone, you can talk just like we're talking and have a conversation and to give information. Excellent quality sound. Military guy working on radios, there'll be times where it's like we have all this radio equipment that probably costs a lot of money, but the sound quality would be absolutely horrible. It's like, man, we'd be better off using cell phones on this mission than these radios. All right, now telemetry. Now, telemetry allows us to transmit patient data to the appropriate facility. Like, let's say we have a patient that is having chest pain, and we have a paramedic that's on scene, and they are getting a 12 lead, an EKG on that patient. While paramedics are trained to read 12 leads, they can submit that 12 lead and all that patient information to, say, the STEMI center, so ST elevated myocardial infarction, serious heart attack. They can transmit that 12 lead for a cardiologist to look at and be like, yes, this is happening. Come to us, code 3. So we can transmit this data quickly. We can get it seen by a provider very quickly. All right. So in a sense, it helps the providers to see what we're seeing on scene. All right, here are some examples of some of our equipment. Now, LifePack 15, kind of new equipment. I was working with LifePack 12, but we're constantly making advances in technology. I mean, hope to the Lord that you guys aren't using this stuff over here. It's a little dated. Now, land mobile satellite communications. Now, you can use this in remote areas. Now, this actually works with satellites. I've worked with SATCOM more on the military side compared to civilian side. But with that, I kind of love-hate relationship with it. It works great because it is able to enable us to have communications when we don't have some capabilities. However, we do rely on those satellites, and sometimes it can take a little bit of time to obtain that satellite signal. Okay, now with the EMS communication system, there are some rules and regulations that are put in place. Those are regulated by the Federal Communication Commission, the FCC. All right, now that will, they'll put out fines for, people who are transmitting on radios without a license. They'll put out fines for, inappropriate radio communications. So there are a lot of rules and regulations that go along with that. Now, also we have system maintenance. Now, from a user standpoint, as like an EMT, paramedic, nurse, you're not going to be, doing like breaking down the radio and troubleshooting a lot of the more technical problems. You want to make sure your radios are clean. Okay, make sure that you are getting them checked out by the techs regularly. Biggest thing when I worked on the ambulance was making sure I had fresh batteries. Okay, when I had the cell phone, when I had the, I think pagers were what we used. I'm sure they still use them today, but when I had all that stuff, I made sure my batteries were good for our 12 leads. Okay, I made sure I had spare batteries, and I did a test every morning before I started that shift. That's going to be part of what you do as the EMT. So we always make sure we have the equipment, we always make sure we have batteries, and we'll make sure it functions before we start our day. All right, now here's a little question for you guys. What piece of radio equipment amplifies a low power radio transmission and rebroadcasts it at a higher power? Okay, so we take low power, okay, transmit it to a higher power, extends our range. Correct answer on this would be repeaters. Okay, now as an EMT, you communicate with dispatch, medical direction, and then receiving facility personnel. So phone and cellular phone communication, okay, format report is the same. I like to think we use like this SBAR, which we'll talk about shortly, situation, background, assessment, recommendations, but ultimately wherever you work, they may have a certain format that they like to receive information. Like I'm a nurse at a hospital. In my hospital, we, want patients, age, sex, chief complaint, okay, vital signs, and then any interventions that you've done, and that's kind of it. Now, when I worked at other counties, when I worked on the ambulance, like I had a page report, and that was how they wanted the report, and they were very, we'll just say, they were strict on receiving the report in that manner that they had laid out for you. Now, with this, beware of cellular dead spots. Have a backup plan. So, like, if you know you're going to be driving through, say, the Cone Pass and radio service and cell phone service going through that pass, or anywhere you're at, you're going to know your area. Anywhere you go, if you know you have a dead spot, if you know I'm not going to have signal when I go into this area, okay, and then the hospital's right on the other side, I need to have a plan. Okay, I'm going to work to send my radio traffic before I hit that dead spot. All right. No important telephone numbers. In our ambulance, we had them posted up on the wall, like all the receiving facilities, like medical direction for base hospital. We had all those numbers posted in the ambulance. Probably progress more to where they're actually saved in the phone. But all right, now with dispatch. Dispatch receives information from callers and directs emergency services to the scene. Now, emergency medical dispatchers provide instructions to the caller while awaiting EMS arrival. Now, the one thing to remember with this is when people call 911, oftentimes it is not a calm, chill, like, hey, they're watching the football game and everything's wonderful. This is, the worst day of their life when they're calling 911. So they may be frantic, and dispatch is trying to receive that information the best that they can. All right. So when they, relay information to you, they may not have a lot of information because they may not have received a lot of information, or they couldn't make a lot of information, make sense of a lot of the information that they got. Now, if you have an emergency medical dispatcher, okay, that is great because they can help instruct that person who called to provide life-saving interventions like providing CPR to a patient prior to your arrival, which greatly increases our patient's chances of survivability. Now, dispatchers may receive information from the Advanced Automatic Collision Notification System and some newer vehicle models. So with that, you think of like OnStar, I'm sure you guys have probably all seen the commercials on television where it's like, so-and-so, we noticed you were in an accident. Are you okay? We're dispatching, 911 to your car right now. And what that program can do is it'll relay information about your accident to dispatch where you're at, and then they can dispatch, an ambulance accordingly. Now, communicating with medical direction. Now, medical direction may be located at the receiving facility or elsewhere. Ultimately, you're going to be calling them when you're needing assistance with a call. Now, we always work under medical direction on every single call, but sometimes, it's like we have like a gray area. It's like, well, a protocol says this, but our patients like walk in that line, like a good example, you have a patient that, is having chest pain. You're going to learn about medications that we can assist with. Well, that patient has chest pain, they have nitroglycerin, however, they have a systolic blood pressure of 92. And family says that, it's like, man, when he takes this medication, his blood pressure drops really low. It's like, all right, well, based off of your protocol, it says you can give this nitroglycerin. But now you're getting information from the patient and patient family that's like, when they take this medication, it drops their blood pressure a lot. And it's like, oh, well, now we have to kind of, it's like, well, do I give them this medication? Protocol says yes, but if I give them it, if they're really sensitive to the med, then that can cause their blood pressure to drop too low. That'd be a bad thing. So it's like, oh, what do I do? It's like, well, the great thing is we have medical direction, someone we can reach out to, talk to bounce an idea off of. It's like, I want to give this medication. It's like, what do you think? And then they can give you orders. And then ultimately it kind of helps, not shed the burden off of you, but it helps one reassure you or helps to confirm what you were thinking already. Okay, now with medical direction, they may give orders and advice. Now be clear, echo any orders back. Okay, I'm sure everybody can understand or think back on a time where you said something and then somebody's repeated it back to you, and then you're like, oh no, that is not right at all. So we always want to echo orders back, ask for clarification of orders if needed, and then if the order seems inappropriate, ask questions. Don't be afraid to question it. Just because it's a nurse, just because it's a PA, whoever it is that you're talking to, don't be afraid to ask questions. Who knows? That person could have been, at the end of a long shift after being on 6 days in a row, and their mind is just zapped, and they're trying to figure out the answer for you, but for whatever reason they made a mistake. Don't be afraid to question them, especially if like, hey, I know my dose of, we'll say aspirin is 324 milligrams. I know that, but they said this crazy number, like they want me to give 1,000 milligrams of aspirin. I'm like, that doesn't sound right. Don't be afraid to question that. Now, with presenting information, we'll use the S-bar kind of approach to organize that information. Okay, S-bar stands for Situation, Background, Assessment, and Recommendation. So anytime like I'll give a report, I talk to somebody about a patient, I'm talking on the phone to a provider, anytime I'll give them this. So situation. It's like, okay, so Dr. So-and-so, I have a 55-year-old male complaining of chest pain. That is my situation right now. Okay, the background of this patient. The patient has a history of 2 previous myocardial infarctions. He has 4 stents that have been placed, 3 years ago. And now I'll give a little bit of my assessment findings. So a patient has a blood pressure of, 170 over 100, heart rate is 90, skin signs are pool pill diaphoretic. And then like I'll give my recommendations or like my plan for this patient. It's like I want to administer, 324 milligrams of aspirin to the patient. I would like to assist him with 0.4 milligrams of his nitroglycerin and put him on 2 liters per minute via nasal cannula. We're going to be transporting to your facility. We'll be there in probably 10 minutes. So that's kind of how we'll use S-bar to organize kind of like a patient report of what's going on. So situation, background, assessment, and then recommendation. Or recommendation I like to think of or your plan of care. Now, once you've given the report, they can say it's like, all right, hey, well, you didn't give me an SpO2 for that patient. What's her pulse ox looking like, And then it's like, oh, pulse ox is, 85. It's like, well, you have that instead of 2 liters per minute, you go ahead and put them on, 4 liters per minute. or something with the blood pressure. They might give you some other recommendations with the nitro or whatever it might be. Now, EMTs must be able to confidently take charge and work as a team with other personnel. Now, I like to think like we are in a very, kind of paramilitary type organization in EMS. You have a lot of, type A type people. Now, always, know what's appropriate, when to take charge and then when to kind of sit back and be a good follower to provide care. Like, I'm sure you can think of a time where you've had two people who are trying to run a scenario and it ultimately didn't go as well as you thought because their ideas were more conflicting. We always want to go with what is always best for the patient. Okay, so one person should be in charge, taking charge, and then everybody else should kind of be, assisting to take care of the patient. Now, radio codes. So there are some advantages and some disadvantages. I've never worked at a place that used radio codes, but the advantages, they shorten airtime. 10-4 is the biggest one that I can think of. It's like understood or copy. But then again, I think understood and copy is just as quick as 10-4. But there are other codes, that mean certain things. That obviously, if I have a code that represents a whole sentence of information, that would obviously shorten radio airtime. Now, some disadvantages you may work with somebody like me who's never worked with 10 codes, and you're giving me all kinds of 10 codes, and I have no idea what you're talking about. So that's a disadvantage of 10 codes. You may not, work with people who understand them. And we do work interagency a lot with a lot of different people. So understand if you work in an area that uses 10 codes, sometimes plain and simple, English on the radio is the best way to go versus 10 codes. Now, times. Clocks must be accurate and synchronous. Okay, military time system is generally used, so we use a 24-hour clock system. So 2 p.m. is 1400. Okay, 8 in the morning is 0800. The way I like to think about it is, for all the afternoon times, your PM times, if it's 2 p.m., add 12, that'll give you your 1400. If it's 4 p.m., add 12, that'll give you your 1600. But everywhere I've worked, even in the hospital, been military times. So if you don't know your military times, I would practice using it, especially while you're in this class. Okay, now patient communication. Okay, so therapeutic communication fosters a positive patient relationship. It can get really easy to get, flustered or, caught up in a call and be short or abrupt with a patient. Now, you really need to always, always, always treat your patients with dignity and respect. Okay, treat your patients like you would want a family member that you care about to be treated. Okay, always use therapeutic communication. Create that positive relationship with the patient because it can allow you to get way more information. Something that really stands out to me is actually a student that I had, and they shared a story when they came back from one of their clinical ride-outs, and it was, he was on an ambulance, paramedic EMT, and then the student, they were just going through the motions of the call, and the student, he asked just a simple question about a picture that was up on the wall, about the family, and made a comment. It's like, it's a lovely family that you have, and just started talking to the patient. Well, that patient ended up opening up in transport to the student about a lot of issues that they were having that were related to the chief complaint. But because that student created a connection to try to build a rapport and to actually, build some kind of positive relationship there, the student received that information compared to like the EMT and the paramedic that were there. So it's amazing how, just trying to build a relationship, build a rapport, talk to people, what that can do as far as the information that you can then receive to better treat them. All right, now patient contact. We always need permission to treat. Okay, so when you introduce yourself, it's like, "Hi, my name's Ron. I'm an EMT. Can I help you?" "Hi, my name's Ron. I'm a nurse. Is it okay if I help you out today?" Now, obviously, they come into the ER. I'm an RN. But I'm going to treat them. We've kind of already we've established a line of consent at that point. I'm always going to keep my patient informed, though, when there's anything that comes up, because, I may have a medication. I've had this happen multiple times where I've come in with like all the meds for a patient that I have to care for. But I'm going to tell them, I'm not just going to start giving them all these injections, or I'm not going to give them all these pills and go ahead and take it. It's like, "Okay, sir." It's like, "Well, this is your nitroglycerin right here. It's going to be, it might make you a little lightheaded, might give you a little bit of a headache, might lower your blood pressure, but it's going to help with your chest pain." I'm going to inform them of all the medications that I have, and then they have every right to refuse any of those medications. And I've had patients refuse a couple because they've had a bad experience, or, whatever it might be, where I try to then educate them on it and be like, "Well, I understand that that's happened here, but I know you had a bad headache with the nitro, but it's really important that we help dilate your blood vessels, especially around your heart. So it's like a headache is a side effect, but it can ultimately, give you a better outcome. Try to educate them, but they have every right to refuse care. Now, control the physical environment, noise and light. This is one thing that I see a lot of people have issues with. Especially when you're new, I like to think of it as like a scene presence. It's like you go into these people's homes, the lights are off, turn the lights on. It's like you go in, they're blasting cops on the television. It's like, turn the TV off. Okay, control the environment so that way you have a good positive patient encounter. Now, communication techniques. Now, these are different things that you can do in order to communicate with your patient. Now, with this facilitation, you're going to be looking at like kind of moving on or moving along a conversation. Okay, so when you ask your patient about, it's like, "Can you tell me about why you called us out today?" It's like, "Oh, well, I'm having chest pain." It's like, "Okay, go ahead, continue. Tell me more about that chest pain. When did it start?" You're kind of facilitating this conversation and kind of giving the patient cues to give more information. Now, clarifying information or clarification might need to be used, like if you ever have like a patient that's like really upset, where they're having an issue actually articulating what's going on. It's like you might need to clarify some information. It's like, "Okay, well, I understand you said that, you're having some pain. Well, could you kind of tell me a little bit more about that pain? Like, how does that feel now?" And kind of help clarify. Now, summary is a big one, because you may have somebody where you ask them what's going on with their pain, and then they open up and they give you a big, long, story about what's happening. Now, with that, you can just take it's like, "Okay, so I understand you're having 10 out of 10 chest pain that's like stabbing in nature. Feels like someone's stabbing you, and it radiates up into your neck. When they've given you paragraphs of information. So we're summarizing it. Now, explanation, that kind of goes without saying. Make sure you're explaining everything that you're doing so the patient has a good understanding of the care that's being provided. Now, silence. Silence can be a positive thing. Silence can also be a negative thing. Okay, advice I'll give you there is read the room, because you may have a patient that kind of they're in the back of the ambulance, you're transporting them, and some people feel like it's like, "Oh, I need to fill this quiet air with words." It's like, no, that's not the case. Silence can be great. Silence can let people reflect. Silence can let people, kind of compose themselves a little bit. Now, that's not to say, silence, is always positive. Silence can be negative. If you're in there and you're doing an assessment and you're needing to look at areas that may be a little private to them, you want to make sure you're talking to the patient, and actually tell them what you're doing versus just going and doing it, just to help them feel a little bit comfortable. Now, Empathy. Empathy is another one. Empathy is different than sympathy. We're not there to feel sorry for the patient. We simply want to show them that we understand. You know, and I don't mean that you have a patient with no legs. You're not going to tell them that it's like, hey, I understand how you feel. It's like, well, you have your legs. Like, you don't understand how I feel. But it's like, hey, I understand that you're upset right now. I understand that I understand that you're sad. Understanding like the emotions that they're having with it. But we're not necessarily wanting to feel sorry for the patient. Okay. Now, confrontation. Confrontation is one that you may need to use. I can tell you, I've had people who, say it's like, no, I don't have any medical history. When we're asking them, and you look, and they have all kind of prescriptions, and it's like, well, it's like you don't have a medical history. Well, what are all these prescriptions for? You have like a big bag of medications. You have lisinopril right here. So do you have high blood pressure? Oh yeah, I have high blood pressure. Okay. I see you have metformin. Do you have diabetes? It's like, yeah, I got diabetes. So you may need to confront the patient sometimes. Now, facilitated communications. Now, what this is talking about, what your book references this as, is kind of supporting the patient so they can communicate. Now, what's interesting is, uh, like, if the patient is needing to write something, or if you're using like a letter board, whatever it might be, you're wanting to allow the patient to still communicate what they want to. So you're not trying to manipulate the message, but you're trying to assist them in, say, pointing to a message. Like, one of the things that I've done, like in clinical rotations, with like work in a special needs facility for kids, and they were able to communicate not through words but through like picture boards. So we had these picture boards for them to communicate some of their wants or needs. Now, uh, in a sense, they are able to go to this board, they're able to pull an item or point to an item, and it would be, say, use the bathroom. They want water. That would be an example of facilitated communication. Now, nonverbal communication. That's where we're getting into kind of not what we say, but what we put out. Okay, distance. Distance can be something that is, learned. I think everybody knows the too close. Like if you're within like a foot and a half of somebody, obviously we're going to be way too close to that person. That's considered like we're in the intimate zone. A general rule of thumb is like 2 to 4 feet is a good distance from the patient. All right. But then also with distance, you don't want to be, like 12 feet away when you're talking to them, especially in times like today. Like a lot of people are like 6 feet apart, is everything that's being put out with COVID. Well, if you're in the other room talking to the patient, it's like, well, what's wrong with me? Like I called because I have chest pain. Like I think my heart, my heart's going to explode. And you're like talking to them behind a closed window. It's like you're not really building much of a relationship with them. All right. Gestures are big, like simply like where you place your hands, like crossed arms, hands on your hips, kind of rolling your eyes, stuff like that. Posture, making sure that you're getting down to eye level with the patient. You're not standing over them. Eye contact, just like silence, can be good. Eye contact can be bad. Now, when I do this in the classroom, I'll lock eyes with somebody and just teach for like an hour, just holding contact with them. I'm just kidding, I don't do that. But I do it for a little bit, but it's amazing how uncomfortable that one person starts to feel because I'm staring at them. All right. Now, just again, read the room. All right. If you're making eye contact with that person and you're talking to them, and they keep like breaking contact with you, like it's showing them, you're making them feel a little uncomfortable. Now, contrary to that, or the flip side, is you don't want to be just looking at your little tough book that you have or whatever you're writing your notes on. You don't just want to be looking at that because it could affect your ability to communicate with the patient. Now, also with eye contact, things like sunglasses. Sunglasses need to come off your face when you're making contact with the patient. Now, that's not to say like eye protection to protect you, that should stay on, but like if you're wearing sunglasses, those should come off. Now, haptics is the study of touching. So with touching is can be soothing. They're showing kind of a picture in the background here, hand on the shoulder showing that you're being empathetic, you're trying to show some compassion for the patient. It can really go a long way with a lot of people. Like a hand on the shoulder for that little old lady that's feeling weak, that, hasn't seen family in a while, could, mean the world to them. But if you go into like a bar where somebody's just had a bottle cracked over their head, you're not going to go, it's like, put your hand on their hand and be like, I understand that you're hurting right now. I'm going to take good care of you. Like, again, read the room. That could be a little inappropriate and, not get the desired response that you were looking for. Now, here's a good example of body language and also haptics, touching. Message here on the left, provider's down on a knee, down at eye level. Okay, has like more of an opened type appearance to him. Okay, he's touching the patient's hand, showing that he has some compassion, compared to provider here on the right, standing over the patient, arms are crossed. It's kind of like, you called me at 2 o'clock in the morning because you can't poop. Those calls happen. I've been there. Like, really, you can't poop and that's why you called. You don't want to be like the provider on the right. All right, remember, it's their emergency. Okay, they called you because they felt like it was a serious thing. Okay, always show compassion. Treat your patients always with dignity and respect. Okay, now communication pearls. Now, ask one question at a time, okay, and give the patient time to answer. We get into this a little bit later with the elderly patients, but allow them time to answer. Now, listen to the response. There's a difference between hearing and listening, all right? I think I've used this example before, but when you are like talking to like your grandma on the phone and they're talking about the birds in the backyard and you're just like, yeah, 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 yeah. You're hearing what they're saying, but then all of a sudden their like voice like changes inflection and you're like, oh boy, they just asked a question and you have no idea what they asked. It's like, oh, what was that? It's like, that shows that you weren't listening. Okay, so listen to the patient. Okay, give them feedback that shows that you're listening. Okay, and what I mean by feedback is, it's like, yeah, my chest hurts really bad and it started 3 days ago, and I just, I when I lay down it helps a little bit, but then I get short of breath, and it's like, you're not gonna be like, oh, okay. It's like, okay, so your chest pain started about 3 days ago and it feels a little bit better when you lay down. Okay, but you get short of breath. You're giving them feedback to show that you've listened and you've heard what they said. Okay, choose language that the patient understands. Do not ask leading or biased questions. You're not trying to lead the patient, to a diagnosis or anything. Do not interrupt the patient. Be aware of too much talking by you or the patient. Do not provide false reassurances. This is a big one. Don't tell the patient everything's going to be okay, because we don't. We don't necessarily know everything is going to be okay. Better thing to say is like, we're going to do everything that we can to take care of you. Okay. Do not give inappropriate advice. Again, we're not doctors. This is a thing that we're seeing right now. Just don't give the patient, advice based on your own personal opinions. Okay. And then always be honest. Be honest. Once trust is broken, we don't have a lot of time with our patients. So once trust is broken, it's going to be impossible to get that trust back with the timeline that you have with them. Now, open-ended versus closed-ended questions. Okay. Now, closed-ended questions called direct questions. Now, closed-ended questions allow you to get information quickly. So like, do you have pain in your chest? Yes. No. You know, you get information quickly with closed-ended questions. Whereas open-ended questions, it's like, can you tell me a little bit about how you're feeling? It's like, oh, yeah, I can tell you how I'm feeling. So my back hurts. And that started about 3 months ago when I tried to pick up this cinder block at work. Okay, and then it just got progressively worse, and now I can't move my left leg that well. And you see that left leg and it's swelling, it's going to tell you how I'm feeling. So, open-ended, you can get a lot of information, but you might get a lot of information that you don't necessarily, need at the time. Whereas closed-ended questions are more direct, allows you to get information rather quickly. Always about finding a balance. Now, some special circumstances, transcultural considerations. Now, this is not a matter of knowing what every culture, you know, thinks or how they feel about healthcare. Okay, knowing that this culture prefers like as a hot cold approach to healthcare, and this culture, doesn't believe in Western medicine or you know not about that. Okay. What I mean by transcultural considerations is not having this ethnocentric view that your way is the best way and the only way that things should be. Okay. Uh, have an open mind. Remember, we've talked about this already. Patients have the right to refuse care. Okay, you may have a culture that does not believe in, this doesn't apply to you as EMTs, but does not believe in blood transfusions, even though they may need a blood transfusion, even though if they don't get this transfusion, they're going to die. If they are competent, alert and oriented times 4, and able to refuse that care, they have every right to refuse it. Okay, and it's not my place to go in and be like, well, this is going to save you and we're going to do it anyway. No, we cannot do that. Okay, so reflect, know your own belief system. Okay, but do not have this, ethnocentric view that your way is the best way and the only way. Okay, now elderly patients, they're double-edged sword here. So what I mean with elderly patients is, there are some declines in health as we age. There's declines in hearing. There's some, not for everybody, but some cognitive changes that occur as people age, think Alzheimer's, dementia. But then you also don't want to have this, again, ageism is a thing, your book talks about it. You don't want to have this view that all older people have problems. I'll tell you, like my grandma, one thing that drives her crazy when she goes to the doctor is when the doctor's like, well, you are 84, it's like, well, sorry, so you don't want to just like, it's like, well, you are old, that's why that doesn't work. It's like, no, that's not the case. um, what I'm saying with this, don't just assume that they have problems, but then if they do have issues, such as hearing issues, you may need to speak slowly. Okay, ensure that they have their assistive devices, like if they have hearing aids, make sure that they're in and they're on. My grandpa doesn't always have his hearing aids, but maybe because he doesn't want to listen to my grandma. But say, hey, grandpa, can you put your hearing aids in? We're gonna chat. Um, don't assume that they have problems, but if they do have those issues, make sure you work with them. All right. Big thing, give them time to respond. It may take them a little bit longer to give you a response back to a question. And it can be very frustrating when they're then spoken over as they're trying to formulate a response. Okay? Young patients. Now, with young people, we have chapter 9, which is going to go into kind of lifespan development and some of the things to consider. So I'm going to hit it very briefly here. With children, it does take some patience. There are different phases that we go through in our childhood. Like I like the yes, no, kind of phase, or the no phase, I should say. It's like where it doesn't matter what you ask, everything is no. Well, a good thing to do with those kids that are always like, no, 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 give them options. Give them options instead. It's like, oh, can I check your belly? No. It's like, okay, well, I need to listen to your lungs, and I need to, I need to look at your belly. Which one do you want me to do first? It's like, do you want me to lift up your shirt, or do you want your mom to lift your shirt? Those are things where you can give them options now, where yes or no isn't a choice. It's one of the two things that you need to do to complete your job. Also, don't speak over their heads. Don't use medical jargon or medical terminology when talking to them, because you could scare them. It's like, okay, I'm going to use my blood pressure cuff with a sphygmomanometer and my stethoscope here, and I'm going to take your blood pressure. It's like, it's my blood pressure. You can't take it. So watch what you say. Don't talk over their head. It's like, hey, I'm going to put this little band around your arm, and it's going to feel like a little squeeze, and then all of a sudden it's going to go, and then it's going to go away. Kind of talk down to their level. Talk to their level of understanding.